Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Winston. How are you doing today?
Very well, Dennis. I'm looking forward to this podcast because it is an area of special interest to me.
Oh, very good. So today I would like to talk about pain and pain pathways. And the reason why is just through different trainings, a lot of different providers have kind of explained the different types of pain, whether it's visceral or somatic or psychogenic or whatever. And at no point in time has any of those definitions actually helped me treat pain. And I know it's just good practice to use multimodal therapy when it comes to analgesia. So I'm hoping that understanding kind of the nervous system and how those nociceptors work, maybe I'll be more effective at using my other therapies so that at the very minimum, I can reduce the amount of my narcotics that I'm actually using.
Yeah, that's a good point.
So, just jumping straight into it, could you please explain explain the nervous system, at least when it comes to pain?
Sure. I've given you 4 diagrams. I'm referring to diagram number 1 now, just to give you an overview of the basic pain pathways. Pain from the periphery to the brain needs to go through 5 processes. So process number 1 is transduction. And transduction is a conversion of energy to initiate a nerve impulse. The second phase is going from the periphery to the spinal cord. Third phase is at the spinal cord, which is very complex, which includes both ascending and descending pathways, which we'll talk about when we talk about the gate control theory. Phase 4 is when it gets to the brain and all the interactions within the brain. And then phase 5 is the descending pathways, which then is responsible for what was simplistically called the gate control theory. So that in its nutshell is the pain pathway. So I'm going to go through it in a little bit more detail now. Let's start at phase 1, the transduction. In the body, especially the skin, but also in viscera and muscle and bone, there are nerves. And it is the nociceptors. Noci means pain. So it's the pain receptors, which are free nerve endings. And I'll for this purpose, I'll just talk about the skin because it's easier to understand it when you talk about the periphery. So some energy onto the skin, whether it's heat, whether it's mechanical, whether it's cold, whether it's chemical, that energy needs to be transduced into a nerve impulse. Once that nerve impulse is generated, you've got 2 different fibers that pertain to pain. One is the A delta fibers, which is myelinated, and C fibers, which are unmyelinated. So if I kick you in the shin, you will get that fast pain through A delta, and then milliseconds later, the bruising sensation, which is the C fibers. So you get your fast and slow pain. When that gets into the spinal cord, it goes through various layers, basically, and crosses to the contralateral side, and then goes up the spinothalamic tract. Spinothalamic, spine, thalamus. The thalamus is like a big airway hub. It's a relay station. Everything feeds into it, and it then diverts the information appropriately. So information from the spinal cord goes to the thalamus. The thalamus then projects that information onto the somatosensory cortex. So that tells you where the pain is going to come from. And everybody knows the homunculus, where the head, the hands and feet and genitalia are highly represented. This is why these are very tender areas. But that is too simplistic, because at the same time, that information goes around the brain, different pain areas, which we'll talk to in a second when we talk of the interactions within the brain. But the same time, there's a reflex. So if you touch something hot, your hand goes away. So there's that reflex action where you withdraw from the pain stimulus. And then finally, from the brain, you've got your descending pathways through the periaqueductal gray. And the periaqueductal gray area within the midbrain is very important for two reasons. One, it's the area where you produce your own endogenous opioids. So those people that do a lot of exercise and get a buzz from it, not me, but the people who do a lot of exercise, that's what they do. That's why exercise gives you extra boost, an immune shot. That is why exercise is so important. And then that comes through down the rostral ventral medulla in the first diagram, through serotonin mainly, and then joins the spinal cord. And that's where that gate control theory occurs. So you can imagine somebody in the heat of battle is shot. They don't feel pain because the descending pathways inhibit onward transmission. But once they get into a place of safety, they feel the smoke, it's wet, it's blood, they feel pain. So what I want people to realize, it's not just a simple nervous pathway, it's a very complex network, which is mainly at spinal cord level and secondly at the brain. So you've got two modulating systems that occur simultaneously. Now, let's just go into a little bit more detail. We'll go into diagram number 2, which is shows the interactions within the spinal cord as well as in the brain. So let's start again at the beginning. So you've got your nociceptors, and we've got a range of them. We've got acid responding ones, opioid responding ones, histamine, the list goes on. The ones that are not regarded as not well known is the TRP, or transient receptor potential receptors, of which capsaicin is one type, which is hot, like chili peppers, and menthol, which is cool. So you've got this thermal range of receptors in addition to the other receptors. Now, for example, in the skin, if you get burned, opioid receptors are activated. So that is why topical morphine works in a burn, because the receptors are activated. They're woken up. So whenever you get an energy that is going to challenge the body, in other words, it's going to cause tissue destruction, that energy is transduced into a nerve impulse through the sodium channels along the nerve fiber going into the spinal cord. Okay? At the spinal cord, layers 2 and 10 are the Rexed's lamina that process pain pathways. They then cross the spinal cord to the contralateral side and run up the spinothalamic tract to the thalamus, the big relay organ. And from there, it goes to the somatosensory cortex, so you know where the pain is coming from. It also goes to the limbic system. The limbic system is a huge complex, which I've shown in yellow, which controls things like sleep, emotions, appetite, endocrine, activation of the autonomic nervous system, etc., etc. So it's a if you like, it's a massive network. So, for example, if you're unconscious, you can still get surrogate evidence of being in pain from the tachycardia, from the hypertension, from the tears, from the sweating. So this is, if you like, the thalamus starts activating all the systems. And so you've got the quick system, the nervous system, and then you've got the slower system, the endocrine system. Now, when you consider the descending pathways, they are mainly, not conclusively, but mainly serotonin. So serotonin is the message coming down the descending pathways. And that explains the use of antidepressants that work on serotonin pathways to make you less depressed. And guess what? Less pain. So as you come down the descending pathways, at the junction of the spinal cord, Melzack and Wall came up with the gate control theory in the 1960s. And basically they said the gate is either open or shut. So the soldier gets shot on the battlefield, doesn't feel pain because the gate is shut. But once he's comfortable and in a place of safety, he feels pain. The gate is open. I think that is a very good way of simplifying a complex of activities that occur. So I still think the gate control theory for the majority of clinical use is useful because you can overrun it. So, for example, if you're using deep breathing, yoga, relaxation, all these non-drug approaches, that's going to reinforce the descending pathways. So when you are providing pain relief to people, please don't forget the non-drug interventions you can do. By just being a nice guy. If you're a nice guy, you induce the placebo response. The placebo response has got no side effects, no overdose, no drug interactions. It is so, you've heard me say this before, but Dennis, to me, it's not what you use, it's how you use it. And if you can talk to the patient, explain to the patient, even if they're unconscious, I'm going to give you an injection I'm going to give you some this, I'm going to do this, I'm going to move you, I'm going to raise your head, whatever. Talking to the patient, even if they're unconscious, because remember, hearing is the last thing to go. It is a huge thing. So that's where the placebo comes into it, the importance of the placebo. And if you look at the limbic system, the prefrontal cortex is where your memory is embedded. So once you know you've had a heart attack and it was preceded by chest pain, so the next time you get chest pain, you think, oh my God, I'm in trouble again, because that's the memory. So the prefrontal cortex can last you a lifetime. When I was 6 years old, I was having my teeth extracted under chloroform in Africa. I was living in Africa at the time. Now, if I go into a dry cleaner, that smell gives me the same nausea, intense feeling of discomfort, etc., because that's a memory from my childhood. So the limbic system, the prefrontal cortex, is important. The other bit is the autonomic nervous system, which is your sympathetic, parasympathetic. And because it's pain, it's going to be sympathetically run. And therefore, you're going to activate the sympathetic system. So all your vital signs that you see in somebody who is even unconscious you're still able to have surrogate evidence of them being in pain. And then as you come down the descending pathways, I told you serotonin is a big player in the multitude of neurotransmitters. That will give you an idea as how antidepressants will work in pain. So that essentially is the important overview of pain pathways. Now, the thing that we have to remember is when we talk about pain in its current classification, which was changed in 2020, we've got three types of pain. We've got nociceptive pain, which everybody knows because everybody's experienced it. It's good pain. It'll go away. Hopefully with time, it'll be faster treated if you use a paracetamol, NSAID, or an opioid, or something like ketamine. But it's acute pain. It'll finish. Neuropathic pain is when the nerves that we've discussed, whether peripherally, the A delta C fibers, are damaged, like in diabetes, or something goes on within the spinal cord and the brain, like in a stroke or multiple sclerosis. Now, if you think about it, if you've got a spinal cord injury or if you've got multiple sclerosis, guess what? Opioids ain't going to work. So we have to understand the type of pain we're treating people if you can tailor make it to the individual need. And the third type, which is really a fascinating subject, is called nociplastic pain. Nociplastic pain is when somebody has pain with no obvious cause, but no obvious damage to the nervous system. So it's neither nociceptive, it's neither neuropathic, but it's in a third category. But it is common as muck. IBS, fibromyalgia, irritable bowel, temporomandibular dysfunction, migraine, vulvodynia, rectal pain. The list is huge, and each specialty will have their own nociplastic type pain. But what is really important for our listeners is that if you don't recognize the nociplastic pain, when you treat the nociceptive pain, the complications get worse. Say, for example, I've got IBS and I've got IBS constipation, okay? You give me amitriptyline as your choice of antidepressant for my neuropathic pain, which we'll discuss in a few minutes. That's going to make my constipation worse. So I would switch to nortriptyline, which is less constipating. So for the practitioner, there's nothing you can do about nociplastic pain, but you need to say to people, do you have any other pain problems? So to summarize, 3 types of pain: nociceptive, neuropathic, nociplastic. Nociplastic is when there's no clear evidence of any nerve damage, either peripherally or centrally, and it's not neuropathic and it's not nociceptive. So it's a new, I guess, classification, which will put all these disorders that we talked about into one bag. So that is what has changed in 2020. So just because the clinicians in the past haven't been able to recognize it, it doesn't mean it's not a pain problem. And I think we need to stop stigmatizing these patients, dismissing them and saying, no, go away. It's all in your head. Because if you've got one nociplastic pain, the chances are you'll have 4 or 5 others. You just got to look for it. Right. And there is at least one member of the military that's actually looking at the incidence of nociplastic pain in his troop. So I think it's going to be a fascinating study. I mean, nobody talks about IBS. Nobody talks about chronic headaches. Nobody talks about vulvodynia. You know, these are subjects which are either dismissed or taboo topics because very little is known about them. So right. That is why I think these pathways are important, so that you can, if you've excluded nociceptive, excluded neuropathic, the rest is nociplastic. It mustn't be dismissed. It must be handled properly. And that's what I hope we will cover today.
Right. Now, talking about the different pathways, one thing it reminds me of is hyperalgesia, where somebody has pain and it's either undertreated or not treated. And because that pathway is activated over and over and over again, the nerve itself gets thicker. If it's myelinated, like the A delta fibers, the myelin gets thicker. Is that true with the entire pathway, or just the nociceptive pain?
No, I think you've got the gist of the problem. Okay, let me give you an example. If I kick you in the shins now, and then I kick you in the same place a day later, that pain will be amplified. And that is the concept of peripheral sensitization. Because what happens in the first kick is various transmitters and autocoids are released in the tissue, and these sensitize the nociceptors. So these nociceptors now are wound up. So when the next barrage of pain comes along, they'll amplify it. So that's peripheral sensitization. And the only way you can dampen that down, besides not being hit in the first place, is the use of non-steroidals, which may reduce the impact of the second insult. May, because it depends on timing. Now, the second point, talking about hyperalgesia, so in other words, pain that is amplified can also occur within the spinal cord and also in the brain. So we call that central sensitization. And one of the features that is fascinating about central sensitization is the wind-up that occurs in the spinal cord. And these nerves, nerve cells, amplify the signal even more. And this process of wind-up is responsible for central sensitization. So you've got a double whammy. You've got peripheral sensitization and you've got a central sensitization. That combination ain't good. But the good news is ketamine reduces wind-up. And that is why it is such a good drug, because not only and we'll talk about it when we talk about the mechanism of action, it works on a principle of minimizing the wind-up that occurs during central sensitization within the spinal cord. That's why it is such a good drug and of huge potential applications, including depression, and we'll talk about that later. So those are the two main things for hyperalgesia. There is another concept called allodynia. Now, allodynia is if I stroke the back of my hand, that feels pleasurable. But if I had a burn to that, and if it's developed neuropathic pain, if I stroke that area, I'll hit the roof. So allodynia is when a normal pleasant sensation is made to feel unpleasant. So you've got hyperalgesia, you've got allodynia. And these are features of neuropathic pain.
Okay.
Okay,
now,
so if you've got hyperalgesia, there's something chronic going on and you need to work out what it is.
Okay. So at heart, I'm a nerd. I love learning about anatomy and physiology, but not everybody is that way. Having this information, how do I use this to actually treat my patients more effectively?
First of all, recognize the difference between the peripheral and the central sensitization. The peripheral sensitization you can do with, for example, non-steroidals, or topical capsaicin, because capsaicin works in the periphery, or menthol, or TENS. Anything that works in the periphery, which will reduce the sensations going into the spinal cord. And don't forget, the most obvious one is lidocaine. Lidocaine will work from the periphery, from when you infiltrate a wound, that's local infiltration, to a nerve block, to a plexus block, to an epidural block, to a spinal block. So anywhere along the nerve, sodium channel blockers like lidocaine can reversibly block the pathway. That is why local blocks, regional blocks, especially for something like the fingers, the toes, or the femoral nerve block for a femoral fracture, are so fantastic. Because if you get a good block, you can just forget about everything else. You have taken a cruise missile to the problem rather than just randomly trying to atom bomb the whole place up. That it's that sort of finesse. So local anesthetic, whether it's topical creams or capsaicin, whether it's in a gel or in a plaster, will take away the transmitters from the nerve endings. And for that period of 6 hours for a cream, or even 3 months in an 8% plaster, you'll get pain relief in things like diabetic neuropathy, osteoarthritis, etc., etc. So yes, you can manipulate it. And then finally, centrally, the most important one is ketamine that we all use. Ketamine is not only good for the acute phase when somebody's traumatized, but it's also good for minimizing, it can't prevent it, but minimizing that wind up that occurs at spinal cord, and therefore reduce the complexity and the intensity of the chronic picture, because the acute and the chronic picture is just a matter of time.
Would you mind explaining the selection of my agents to actually affect, your ascending or descending pathways?
Yeah, sure. So you want to go through the pharmacology, really?
Yeah.
Yeah. Okay. But before I go to that, can I just quickly talk about phantom limb sensation and phantom limb pain?
Sure. Is that on the third one? There you go.
Yeah.
I got it.
So I've had my hand amputated in a accident. The brain is still getting information from what it thinks is a still functioning limb. But there isn't a limb. But the brain still thinks so. So there's a discord between what the eyes see and what the brain feels or senses. And it's that complete incongruousness that actually starts the whole process of phantom limb sensation and phantom limb pain, because the brain is still not accepted or understood that an amputation has occurred. But the nerve fibers at the end of that amputations become epileptic-like, so they start firing. And because of the firing, you get pain. So it's a neuropathic pain, and that is why opioids don't work. That's why the anticonvulsants, antidepressants may work. But what is interesting, if I've had my hand amputated and I now take a mirror to my good hand and look at the mirror, I can see two hands now, which are normal. So if I move my good hand, eventually the phantom, which the brain thinks is still there, will now understand and feel that there is a full limb. And that's the basis for mirror therapy by Ramachandran from San Francisco. So mirror therapy fools the brain into thinking you've got two normal upper limbs, when in fact you only just got one. So what it does, it changes the neuroplasticity in the brain. What does that mean? You mentioned the myelin sheath and how it modifies, and how the glial cells and the support cells all change the behavior of the nerve. That's called neuroplasticity. Now, you can't just take a wire out like you do in a house, electrical system in a house, and put a new wire in. Because once it's changed for life. So neuroplasticity occurs within the peripheral nervous system as well as in the central nervous system. And that is why you get chronicity. That is why you have to change your analgesic choices, because now it is no longer nociceptive. It's more likely to be neuropathic, plus or minus nociplastic. Okay. So we need to move away from that WHO analgesic ladder, because that is good only if you look at the fine print. It says plus or minus co-analgesics or adjuvants, which are basically drugs whose primary effects are not pain relief, but whose secondary effects are pain relief. And we'll consider that as we go through the drugs.
Okay. Going to slide 4. So, all these, very good information, understanding the different pathways, different effects of different types of pain, and where that pain kind of originates or where it activates within the body. How do I use this information to provide a better, like a multimodal type treatment?
Okay, so before we go into the choice of the drugs, we need to understand the identity of the pain. What is it? Is it purely nociceptive? Is it neuropathic? Is it nociplastic, or a combination of all three, or in different combinations? So that's the most important thing, and that is from history. The neuropathic is really, I think history is so important, because whether it's nociplastic, neuropathic, or nociceptive, it's all from the history. Have you had hyperalgesia? You don't say hyperalgesia, but you say even light touch make your pain worse. That's allodynia. So it's the history taking, and nociplastic is really just a global question. Do you have pain anywhere else on a long-term basis? So that's the first thing. The second thing is to look at the trajectory. What are you talking about? Something that just happened 5 minutes ago, 5 days ago, 5 years ago, 5 decades ago. So you need to look at the trajectory and what are you trying to achieve? And I think the most important thing is, whatever you choose, the aim is not just to give pain relief, but it's to improve function and quality of life. That is why there's been such a swing now against opioids, because we know that since the 1990s, opioids were sold as, the best things since sliced bread, mainly fueled by pharmaceutical companies because they want to make money. So the pendulum has now swung to a non-opioid basis and using other drugs that may have analgesic activity, and I'm going to go through those in the next few examples. So I'm going to start off with acetaminophen or paracetamol. Brilliant drug, and I'm ashamed to say nobody knows where it works. We think it may be a COX-3 inhibition. We may think it affects the serotonergic pathways, descending pathways. It may work on the cannabinoid receptor. It may work on the TRP. It works on the sodium channels, potassium channels. Nobody knows. But it's brilliant because it works centrally and peripherally. Centrally for its antipyretic effects, and peripherally for its nociceptive effects. So in a situation where you've got somebody who's traumatized, which is essentially nociceptive to begin with, a gram of paracetamol, whichever route that is available to you, will act as an opioid sparing activity and act as part of a multimodal. Okay, so that's your paracetamol. Your NSAIDs, which are either selective or non-selective. So non-selective work on COX-1 and COX-2 enzymes, but the selective just works on 2. So COX-1 is regulation of homeostasis. So your platelets, your gastric mucosa, your renal function. So if you mess that up, you get problems with bleeding, renal and gastric mucosal bleeding. COX-2 is only activated during pain and inflammation. So if a drug can selectively knock that off, you're going to get a better analgesia with less side effects. And the typical drug here is meloxicam or celecoxib. However, I'm very careful about using these drugs in the acute phase, because you do not know what the renal function is going to be like in the next few hours. Because the kidneys could be knocked off from hypovolemia, from direct effects of shock, or radio opaque dye, or whatever. So I don't use it in the acute phase. I use it when everything is a little bit more stable and I've got a handle for the situation. So I'm a little bit scared of using non-steroids as part of my multimodal. Aspirin, just to put that into brackets, irreversibly blocks off COX-1 and COX-2. NSAIDs reversibly block, this one irreversibly blocks. So if somebody's on aspirin for the next 10 days till the new platelets are regenerated, it ain't going to work. That's why you've just got to be careful about aspirin. Fortunately, It doesn't use much now. So that's your acetaminophen and the NSAIDs. Lidocaine blocks off sodium channels.
I'm sorry, I just had one quick question about acetaminophen and NSAIDs. We'll kind of just group them up. To what amount of relief from analgesia can I hope for? Like, is this something that's going to reduce it like a minuscule amount and I'm just being fancy? Or is this something that can measurably reduce my opioid or my narcotic consumption?
Good question. Major trauma, a gram of paracetamol is equivalent of 10 milligrams of morphine IV.
Okay, absolutely.
So it is very good. So for me, paracetamol with morphine would be my first to go to drug, because that's the most commonly available for most people. My first choice is actually ketamine, but that's we'll come to that in a second. But morphine or a opioid and a paracetamol, a good starting point.
Nice. Lidocaine?
Lidocaine reversibly blocks sodium channels and potassium channels in every nervous tissue. So it's not just nerves, but heart and brain. So if you mess up with the lidocaine, you can get cardiac arrhythmias through the class 1B classification and cause epileptic fits. So I just put that in because people, you need to treat that drug with a great amount of respect. But like I said to you earlier on, it can work anyway from the periphery, topically like Emla cream, or you can work as a local infiltration, a nerve block, a plexus block, epidural, and a spinal. So that armamentarium is not open to most of us, but anesthesiologists have that under the belt. For most of us, I guess it's a major nerve block, like an ephemeral nerve block. Very, very useful. Now, the other thing which I find fascinating, lidocaine, especially in osteo conditions, is bacteriostatic. Okay, so you've got an added benefit from using lidocaine. Okay, I mean it's just stuff that people talk about. That's what they mean. It doesn't kill the bacteria, but it prevents them from infiltrating. So you got an infected wound, osteo conditions, you get a little bit of a bonus from that.
Nice.
The next one is chilies, capsaicin. It's one of my favorite drugs to go to, because although it's not used in early acute, it is a very useful drug because it's available everywhere in the world. The active ingredient in, for example, in Tiger Balm is capsicum. So if wherever you travel, you can get this. So that's why I like it. It blocks C fiber conduction. That's how it works. So if you apply it, it's the C fiber, it's unmyelinated fibers. What the capsaicin does is empties out the neurotransmitters. And if you don't have neurotransmitters, you can't get enough transmission. So it works that simply. Specifically, it works on the TRP, or the transient receptor potential vanilloid, TRPV1. It's a big mouthful, but that's how it works. It works for acute pain. It works for chronic pain, osteoarthritis, diabetic neuropathy. Fantastic. In burns, if you've got a hypertrophic scar, you can apply a capsaicin and it might give you pain relief. So it is very good for neuropathic pain. Okay, so if you suspect neuropathic pain, and it's available everywhere in the world, it's the go-to drug. And it's not just chili peppers that got capsaicin. Turmeric has got curcumin, black peppers have piperine. So, in other words, I think the future of pain relief is going to be herbs, because that's the obvious place. So that's how capsaicin. So capsaicin is on the hot side, menthol is on the cool side, and that works on the TRPM8 activator and gives you cooling sensations. It works on the spinal cord and the trigeminal ganglion. Some people get good relief. You've just got to try it and see it. It's not good for the acute phase, obviously, but it's good for the chronic phase. Do you remember the days of menthol cigarettes? The menthol in the cigarette was just to provide the cooling of the trachea as you inhaled your cigarette. I thought that would be just an extra bit of information in the next bar quiz.
Right. So, I mean, is there any way to decide whether you need capsaicin or menthol, or is it you try one and if that doesn't work very well, then you try the other?
Generally speaking, capsaicin is your number one drug to go for. Menthol, very rarely.
Okay.
So that's your menthol. And opioids, everybody knows. Opioid receptors are everywhere in the body, peripherally, on the skin, especially when it's burned, osteoarthritis in the joints, in the gut, which is why you get constipated, centrally, which is why you get your pinpoint pupils and you vomit. So it's everywhere. The terminology has changed in that we used to call them the delta, kappa, mu receptors. Now we call them DOP, COP, MOP, and NOP. Basically the same thing. They all work. The mu receptors, I'll go back to the old terminology. Mu receptors is where the morphine works. Fantastic. Again, we're becoming very aware that morphine used in a chronic situation, you develop tolerance, and then you develop dependency, etc., etc. Now, do you remember in the diagram I said to you, the pain pathways go up into the brain, and then they go into the various, activate the various other systems, like the autonomic nervous systems, the endocrine systems. And guess what? Opioids are responsible for lots of things in the body. They are responsible for appetite, for sleep, for regeneration, for immunity, etc. So it has got lots of non-analgesic activities. And in fact, all the problems that a drug-dependent opioid patient has are from the side effects of opioids. And the one thing that is really sad is that in a male dependent opioid dependent patient, the testes actually shrink. So in other words, the hormonal impacts of morphine need to be made very clear. Because not only do you lose your testosterone, which has an impact from your cardiac health, your bone health, your muscle health, and your well-being, but it also affects your fertility. So it's not as simple as saying, oh, these are the opioid receptors. So that's why we've gone through a shift of not using opioids as much as we used to. The opioids can be natural, like you have in morphine. It can be semi-synthetic, like oxycodone, or it can be completely synthetic, like your fentanyl and all the fentanyl derivatives. But generally speaking, we like to use it now for the acute phase and get them off as quickly as possible. The next one is your cannabinoids. These receptors are important for lots of things: energy balance, appetite, metabolic regulation, anxiety, bone growth, immunity, and guess what? Pain. So there is a trend now to use CBD. So there's a lot of evidence, but it's not evidence-based information acting on either CB1 receptor or CB2 receptor. And I think the jury's out. We still don't know where they fit into the armamentarium. If somebody says to me, I apply a cannabinoid oil on my chest and the pain in my toe goes away, and provided they're not spending a lot of money and there are no side effects, I'm happy with that, because that's the placebo response. Okay, so I think we've just got to be a little bit careful about dismissing people's beliefs, because if somebody believes something is working, I find it difficult to take them off it. So I leave them well alone.
Okay.
Now, the next drug on the ascending pathway is ketamine. I told you it works on the spinal cord, reduces the wind up, and it mediates this through the NMDA receptor, glutamate receptor, and opioid receptor. One thing about ketamine, not only does it reduce wind up and therefore central sensitization, it's also good for neuropathic pain. It's also opioid sparing. So if you use a little bit of ketamine, you may use less of opioid. Now, I say this with caution, Dennis, because I want only experienced people who've handled these two drugs to be able to use it in combination. Remember, a drug combination has more than double the problems. But what I'm saying is, if I'm trying to get somebody off an opioid and they still require ketamine, say, for example, in a traumatic amputation, which you know it's going to be neuropathic, you're better off moving to the ketamine rather than relying on the opioid. Do you see what I'm trying to get at? So it's the nature of the pain you're treating and what the trajectory is going to be. So ketamine is good for opioid sparing. It works on the glutamate inhibition and NMDA. So it's got a lot of receptor profile, which is useful. And the other thing is very few patients are ketamine dependent. So you won't get the problem of tolerance or that you normally get when you're treating somebody who's already opioid dependent acutely. You haven't got that baggage. It's relatively a small problem. Just as a aside, those who abuse ketamine, the ketamine is metabolized, and it's when it's in the bladder, it actually shrinks the bladder. And this is a big problem in China with ketamine dependency and ketamine addiction. So that is something that's important. And then finally, the nice thing about ketamine, because it works on the NMDA receptor, it also influences memory. So the pain and memory may be modified, and therefore, hopefully, less PTSD. So there's some things nice about ketamine. It's becoming more popular in the States and in Europe for its use in depression and use in suicidal ideation. I have no expertise in those areas, but I'm watching that with great interest because we just don't understand how the complexity of what goes on in the brain works, really. We're just beginning to understand that. So I'm a big fan of ketamine, particularly useful for its neuropathic pain. It's easily available anywhere in the world. It covers all possibilities. You can use it as an analgesic in low doses, higher doses than an anesthetic. So it's got lots of flexibility as well.
Yep.
And then finally, on the descending pathways, there are two groups of compounds that we have not discussed. One is the anticonvulsants, and the other one is the antidepressants. Anticonvulsants are now known as anti-seizures. I don't know why they've changed it, but that's the latest terminology, anti-seizures. So they're used for epilepsy, but they're also used as adjuvants or co-analgesics in chronic pain. Now, the beauty about this is that if you've got neuropathic pain, say, for example, sharp shooting pain or firing, I always get my patients to take these anticonvulsants by saying you've got epilepsy of the periphery. So in other words, a lower threshold in that nerve that's damaged, so it fires off spontaneously. Therefore, the only thing that may help is an anticonvulsant. And then you can make your choice which one you go for. They all work in a fairly similar fashion. They affect the sodium, potassium, or calcium or chloride channels in varying difference. So in other words, if you try somebody on pregabalin and it doesn't work, they may work on gabapentin or vice versa. So I always go for pregabalin as my first choice anticonvulsant. Remember, it takes 6 to 8 weeks to work, so it's not going to work immediately. It's not like your opioids, it's not your paracetamol. These drugs take ages to work. So I always say, because they're sedative, because they're anticonvulsant, the first few days of therapy, first 2 weeks, they'll get better sleep because they've got a degree of sedation. The second to the fourth week of therapy, they might feel a bit better because they're less in less discomfort. And then finally, at the end, is once the pain is reduced, not abolished, reduced, then you talk about a better quality of life. And one of the dangers here is you have to say to the patients, these drugs don't work instantly. We talk about 6 to 8 weeks before you see some effect. And the second is just to make sure that because it's a sedative, all other sedatives, so your alcohol, your barbiturates, your benzodiazepines, all interact. Anticonvulsants, whichever you guys are allowed to use, just choose one and be good at it. Because for a first line, neuropathic agent, it works.
Okay.
It reduces anxiety, it improves sleep. So it's got other activities that are also a coincidence rather than the primary agent. Antidepressants, on the other hand, there are 5 groups of compounds, and I'll quickly go through these because just to make people realize, we don't really know which transmitters are affected by which type of antidepressant. The commonest one is tricyclic antidepressant, amitriptyline, nortriptyline, whatever. And they all work on noradrenaline, 5-HT, and noradrenaline. So it's a dirty drug. So the tricyclics are dirty because they have effects on several receptors. Therefore, they have more side effects. But guess what? If you consider the whole list of neurotransmitters in the body, if you're a betting man, you would take a tricyclic. Okay, so we haven't got to the stage where you put your finger into an instrument and it tells you what your neurotransmitter deficit is. We don't. So all antidepressants work by increasing the monoamine transmitter within the synapse. So either the majority of the times you reduce the uptake from the synapse. So all these are basically the reuptake inhibitors, whether it's serotonin, whether it's norepinephrine, it doesn't matter which. But basically, you've got more monoamines in the synapse and in the brain. That's how it reduces depression, because you've got more of the good transmitters, and therefore that's how they work. That's a very simple way of looking at antidepressants. So you've got your tricyclics, like your amitriptyline, you've got your SSRIs, which based on serotonin, and these like fluoxetine, citalopram, etc. You've got your NRIs that work on noradrenaline, SNRIs that work on serotonin, norepinephrine, of which amitriptyline, nortriptyline are also in that classification. The drug I'd go for is amitriptyline or nortriptyline. Very low dose, lower than that for depression. So an antidepressant like amitriptyline, you need it in a lower dose than for depression. So we're talking about doses of 10 to 50 milligrams. Taken at 1900 hours, because you don't want them to be sedated the next morning. And I always start my patients on 10 milligrams, especially a fit soldier. Warn them about the side effects: dry mouth, feel a bit queasy when you wake up in the morning. First 2 weeks, better sleep. For next 4 or 5 weeks, better pain relief. And guess what? Last 6 to 8 weeks, better mood. Win, 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 win.
Right.
But there is a stigma about antidepressants, which I find very difficult. And this becomes a problem in the military, where if you are on these drugs, you cannot function and cannot service. But I want my listeners to realize being in pain on a chronic basis also increases neuroplasticity and shrinks the brain volume. So it's a balance of being in pain and about having pain relief. So what I say to my patients, if I put you on amitriptyline, I'm hoping for a 30% reduction in your pain levels, 30%. Now, here's the joke, Dennis. 30% is a placebo response.
Okay.
So I know if I treat my soldier nicely, treat my patient nicely, I'm going to get the placebo response because I've explained to them in very simple terms what the situation is, and also the benefits of the drug. And when they can recognize better sleep, better mood, and less pain, 30% is a bit of a con. I use that often because quite often patients say it's actually more than 30%. And I just shrug my shoulders and say, great.
Yeah.
And then you keep them on that, titrate it according to response. And then when you think they're ready for it, wind them slowly. So wash in slowly, maintain, wash out slowly. And amitriptyline is cheap, easily available, and I use nortriptyline in my patients with constipation, like in IBS. Then I'll use nortriptyline. It is less sedating and less constipating. So just 3 drugs: pregabalin, amitriptyline, or nortriptyline, and that basically would be my recommendation for anyone working on their own for long periods of time, dealing with patients with chronic problems. And then obviously you can refer them on to the pain clinics or to whoever is relevant. But that, in a nutshell, is like my take-home message. Don't ignore the non-drug things like TENS, heat, cold, vibration, support, splintage, all those things. Don't forget the psychological things, explaining what's going on, telling what you're going to do, tell them why you're doing something, giving them that confident approach to their pain relief, taking a bother to get the history right. So in other words, in the history, you're looking for nociceptive, neuropathic, and nociplastic. And if you can do that, I think patients are going to get better care.
When it comes to the pain pathways or understanding, how to treat some of these maybe more chronic type pains more effectively, is there anything else that we really need to know?
I think if a sole practitioner just uses the drugs we talked about, so for the chronic, capsaicin is a go-to drug. I like capsaicin. Choose your anticonvulsant. Mine is pregabalin rather than gabapentin. And I'll tell you why. A is better. B, it works linearly. So if you double the dose, you get double the effect. Gabapentin, you get exponential. I haven't got time for that. And more importantly, gabapentin is 3 times a day. Pregabalin is twice a day. So the logistics as well. So if you stick to your WHO analgesic ladder, plus an anticonvulsant of your choice. Mine is pregabalin. An antidepressant. Mine is definitely amitriptyline / nortriptyline. Capsaicin for anything peripheral nociceptive. I think you could manage most things on that combination.
Nice. Well, again, thank you very much for going through this with us. I definitely feel a little bit more empowered when it comes to treating my teammates, that essentially everybody has chronic pain from doing what we're doing.
Yeah. It's a pleasure.
Cool. Have a good night.
And you.
For today's podcast, be sure to go to our website, www.prolongedfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out. Boy, it's waiting there for you.